Okay, we'll just give it a few minutes and then we'll start. Get underway at 5 minutes past. Right, guys, I think we'll make a start. So today, just to introduce myself again. So my name is Jack. I'm one of the FY2s that works at Salford. This is the musculoskeletal edition of this ongoing revision series. So we have so far covered cardiology, respiratory, and Rob has covered gastroenterology with you on Monday evening. We're going to carry on with this sort of program series with a little bit of rheumatology, orthopaedics, and trauma. So what we're going to do today, we're going to go over a quick systematic approach to joint examination. We're going to illustrate some key musculoskeletal topics using multiple choice questions, and we'll cover some tips and tricks for sitting your exams. So similar format to previous weeks. There's a little bit of a slight difference. There are loads of joint examinations, so we're not going to cover all of them because there are too many to go over in the time that we've got. What I want to just try and reiterate to you is just a system for doing it, and that is look, feel, and move. That should be the method that underpins any joint that you're asked to examine in an exam. So whether it's shoulder or hand or hip or knee, foot and ankle, make sure that you're always following this pattern of look, feel, and move. And then following that, they may have some special tests. So for the hip exam, for example, you'll do your Trendelenburg test after you've done look, feel, and move. But for each joint that you do examine, you should be following this pattern because that's going to help you pick up your marks. What I'm going to do is run through a few different conditions that I think could potentially be things that you might encounter in your exams. So obviously in previous weeks we've simulated a patient to go through the exam, but because there's so many joint exams, we won't go through everything. So we're going to take a look at some signs that you might find for presentations that may come up relevant to the musculoskeletal system. So general points, take a look from the end of bed, always applicable. It's just going to give you an idea of what's going on before you start getting into this routine. Asking about pain is really important, because a lot of the marks that you'll get when you are being tested, it comes down to your patient manner and being considerate and thoughtful. Nobody's expecting you to be a rheumatology consultant at this stage, but the bare minimum that you'd be expected would be to not cause patients undue pain. So if somebody has got a joint condition, it's liable that they may have painful joints. So just ask them before you start moving their shoulder or moving their hands and squeezing their knuckles. Just ask them, have you got any pain anywhere? And when they tell you, just bear that in mind. It doesn't mean don't examine. I remember from my first clinical year at medical school, there was a colleague of mine who sort of very proudly declared in the station where we'd been asked to do a shoulder exam, he asked about pain, and the patient said, I've got pain in my shoulder. He very proudly declared that the patient has pain, I cannot examine the shoulder. And of course, that's not the right thing to do. You have to do what you can, but be considerate. And that's why this point about active movement first and then passive movement is a great screening tool. When we say, look, you're looking for deformities and swelling and wasting and that kind of thing, asymmetry between the two sides, always compare left and right together. If somebody has a normal side and an abnormal side, I would tend to examine the normal side first and then the abnormal side, and ask them to do the movements for you first. Ask them to do it themselves, because then that gives you an idea of what range of movement they have and what they can tolerate. And that way, when you start doing your passive movements, which may be a little bit more uncomfortable because you may stretch them a little bit further than they're comfortable, you just know how far you can take it without causing undue discomfort. At this point, be considerate, be gentle. That's going to go a long way in joint examination. And learn the language. I'm going to talk to you a little bit more in just a second about the vocabulary. It's really important to make yourself look slick in joint examination, in data interpretation with these MSK exams. If you use the right descriptive words, you're going to make yourself sound really clever, really clued up. So think about what might come up, and it's going to be chronic stable conditions if you're getting a patient that has actual signs, and we'll come on to that. So rheumatoid arthritis is a really easy one for them to find because it's a really common condition, and it has some very obvious and very distinctive signs you can find. You would hope nowadays to not find people so much who have late stage arthritis like this. You can see some of these like classical features here. So that's Boutonniere's deformity of the thumb, or Z thumb. I can convince you, hopefully, that if this were the other hand, you would see a Z in that thumb. Ulnar deviation, and that's important. So obviously the ulnar is on this side of the hand. Knowing that the fingers are deviated towards that, and then swan necking, which is hyperextension at the proximal interphalangeal joint, and then forced flexion at the distal interphalangeal joint. Just knowing about some of these signs and how to describe them will be really useful. Osteoarthritis. So again, it's a really common condition. Lots of people have it, so it may well come up in your exams. The way that I like to think about osteoarthritis is signs. So you get these swellings of the proximal and distal interphalangeal joints. You have got Bouchard's nodes at the proximal and Heberden's nodes at the distal. And the way that I was taught to remember that was, if you think of your hand pointing your fingers up towards the ceiling with your thumb sticking out, if you think of that like the British Isles, with your thumb being Cornwall coming off here, Cornwall and Devon, then you've got Birmingham for Bouchard's is in the middle, and the Outer Hebrides for Heberden's nodes is at the top. So that is how I remember which joint swelling is which. And I say that's a really common thing that can come up. going on from osteoarthritis is joint replacements. So you may have somebody that has got a scar that looks like this, which would be obviously a total knee replacement. The slightly more subtle scar of a total hip replacement. Alternatively, these joints can be replaced with a scar that goes along the buttocks, but this scar is more common nowadays. So just think, if somebody may not have pain and stiffness, but a scar like this can suggest previous disease that's been treated. Psoriatic arthropathy, again, you would hope not to see somebody with hands that look like this nowadays. When you're checking the hands, an important thing to do is to check the elbows, because that shows the examiner that you're sort of really clued up as to what you're looking for when examining the hands. If somebody has swollen joints or hand pain, and that's the brief that you've been given for your hand and wrist exam in your OSCEs, checking the elbows for psoriatic plaques is definitely going to make you stand out amongst other candidates. Systemic sclerosis is something that's got some very obvious signs. It's a lot rarer than the conditions that we mentioned previously. So rheumatoid and osteoarthritis are both really common. Psoriatic arthropathy less so, and systemic sclerosis is even less common than that. You get this tightening of the skin on the fingers. This is microstomia that you can see here, tightening of the skin around the mouth. The reason that I put this in is because Salford is a regional centre for systemic sclerosis. So although it may not be very common nationally, the kind of patients that are going to be on the books around here, there could well be a lot of patients with systemic sclerosis that would be asked to come in for the sake of examination. So just, you don't need to know loads about it, but just have an awareness of what this looks like and what other features might come with it. You can see on the lips here some telangiectasia, which fits with the crest syndrome that you see described in textbooks, which is calcinosis, Raynaud's phenomenon of the fingers, esophagitis, sclerosis, which is this tightening of the skin, and telangiectasia. Other things that fit the bill that may not be immediately visible, but things that you could definitely be asked to try and pick up on. So if you're examining an elbow, they might give you an epicondylitis. Tennis elbow or lateral epicondylitis, the way that you test for that, squeeze firmly over the elbow, and with your other hand resist, and with the patient for lateral epicondylitis, it's resisting them, making a fist and extending at the wrist. And if you're resisting at the wrist there and pressing firmly over the lateral epicondyle, that movement's going to recreate pain, and that would diagnose tennis elbow. That's quite common. Golfer's elbow is about 5 times less common than tennis elbow. And the way that you do that is squeeze over the medial epicondyle and resist them, making a fist and flexing at the wrist. And again, if that causes pain, that's a positive indicator for golfer's elbow. It's likely, so the reason I put these ones in italics is because they would likely be simulated patients. You're not necessarily going to have people that actually have these signs, but they're very easy to fake. Somebody just says, oh, that's sore there. Rotator cuff injuries, so know your muscles. That if you're doing a shoulder exam, know the muscles that are responsible for adduction, abduction, internal, external rotation. And if somebody has pain or a reduced range of movement, know which muscle deficit might be responsible for what you're seeing. Adhesive capsulitis, again, frozen shoulder, so know about who tends to be the demographic that gets adhesive capsulitis, and know about how it might present on an exam. Again, it's very easy, and this was in my 4th year exam. This is the shoulder that my colleague didn't want to examine because of pain. Of course, you should just be considerate of that patient that you've got in front of you. Expand, so I think spinal exam is one that probably less likely to come up, but they could ask you to do it. And again, this is a chronic condition that patients are normally very stable with, so could be something that could come up. Hip abductor muscle paralysis, there's lots of reasons for this. It can be down to injury, it can be down to osteoarthritis, and this is a problem that would give you a positive Trendelenburg test on a hip exam. And knee ligament injuries, just knowing when you're doing like your lateral stretch and your anterior draw and your posterior draw, if somebody reports pain, know which movement to associate with which condition and what you're testing for each time. Again, all of these ones in italics are things that are very easy for them to give you an actor playing somebody having an injury, and then for you to tease out what exactly is going on. And then with wrapping up the exam, as always, thank the patient, offer them help if they need it. With joints, it may well be that they have a functional deficit. So if you've asked a patient with rheumatoid arthritis to roll their sleeves up so that you can see their elbows, if you think they might need help, just offer them just help rolling their sleeves back down again or putting their coat back on or whatever it might be. Wash your hands, clean your stethoscope, and present your findings, taking care to describe them in language that is fitting of exams. So vocabulary, this is just going to be a quick run through of some of the words that describe the anatomy, because MSK is very reliant on your anatomical knowledge. When you're describing in orthopaedics and rheumatology, you're always thinking about the anatomical position. So this is the anatomical position. You want to think about this being the ventral surface, and on the back we've got the dorsum. You want to think about the different ways that each joint you might be describing, what movements they can perform. So at the shoulder, you've got abduction and adduction, you've got flexion coming out towards us, and you've got extension of the shoulder coming away. You've got internal and external rotation at the shoulder. At the wrist, you've got a radial side and an ulnar side, because of obviously with that rotating, it can change. So think about, that's an absolute descriptor, radial side and ulnar side, in the same way that like port and starboard would be absolute descriptors on a boat. And think as well about pronation and supination. Think about, I think I've got some illustration here of the spinal curvature. So this primary curvature, which is in the thoracic and the sacral regions, the reason that's described as primary is because as an embryo, you're all curled up in a ball. And then after birth, these lumbar and cervical lordotic regions develop. So if you were to see somebody in exam who's got hunched back, that's kyphosis. So remember that this is the primary curvature, it's a kyphotic curve, and kyphosis would be a exaggerated development of that part of the spine. Scoliosis is this lateral curvature, and you may see patients that have both those together. Stop for a second. I'm just going to mute everybody because somebody else is making noise. Right, let's carry back on. So you may see X-rays of patients that have scoliosis or kyphosis, and then varus and valgus deformity as well, which is relevant to examining patients, but also to describing fractures on X-ray, which is definitely something that could come up, and we're gonna cover a little bit more about later on. So I think that the knee is a good way to illustrate and demonstrate what varus and valgus mean. So with fractures and with deformities like this, we sort of refer to the distal segment in relation to the proximal segment. So if there were a fracture, you're describing the location of the distal segment relative to its proximal part, and with deformity at the knee, it's the distal segment, the tibia and fibula, relative to the femur. The way that I was taught to remember this, so with varus, what you've got is deformity towards the midline, and with valgus deformity, you've got laterally and away from the midline. So valgus has an L in it, and the distal segment moves laterally. So valgus L laterally, moving away from the midline. And with varus, this is sort of bow-legged. These are knock-kneed. If you had, the way that I was told to remember this, if you had a pig farmer, a German pig farmer, he is bow-legged and the pig makes a break for the gate, he's not going to be able to stop him because his knees go apart and his feet move towards the midline. This big gap, the pig's going to run through, and the farmer will be saying varus to pig. So that would be how to remember that. So varus to pig is bow-legged, and then knock-kneed, your distal segments go laterally, pointing away, and that lateral pointing is for valgus. Okay. Fractures, as we've said, we're going to describe the distal segment in relation to the proximal segment. So what you need to think about is the bone that has been affected. You want to think about the part of the bone that's been affected. You want to think about what is the type of fracture. So is it a transverse fracture? Is it an oblique fracture? Is it a spiral fracture? Is it comminuted? So lots of little pieces. And you want to think about how the bones have moved. And those are the different ways that you can think about describing a fracture. So these are the descriptions of the shape of the break in the bone itself. So transverse and oblique are simple fractures, spiral and comminuted getting a little more complicated. I think if you go back to this one, you can see that this is probably a spiral fracture, because what we've got here is an anterior lip that is cut off here, and then we've got that posterior lip that you can see is moving up the bone. So transverse would be going the shortest distance between the two sides of the cortex. Oblique would be, this would be oblique if this lip was as high as that side, but because we've got differences both laterally and anteroposteriorly, this is a spiral fracture. Comminuted is the pieces. Segmental is when you've got multiple breaks in the same bone. Avulsion, that tends to be where a tendon rips a small part of the bone that it's anchored into off. Impacted is down to crush injuries. Torus is where you've got the sort of beginnings of the healing process happening, and green stick is down to pulling force, making a fracture that doesn't go all the way through to the other side of the cortex. So when we're talking about how the bone is moved, which is an important part of describing a fracture, you want to talk about displacement. So displacement is moving, how far does the bone move from its original location in terms of distance? Is it non-displaced? Is it partially displaced? Is it completely displaced? So this would be complete displacement. Angulation is how much it tilts away. So shortening is obviously, as it describes, the bone has completely broken and the muscles have contracted to pull that distal segment of bone closer to its point of origin. And rotation is obviously that distal segment has twisted. So this is again coming back to that varus and valgus deformity. So the normal line of the femur would be coming down, and you can see here that a force from the lateral side looks to have hit this bone, broken the femur, and the distal segment, the distal end of the distal segment, is now pointing laterally. So that's a valgus deformity. And here, a medial force appears to have broken the femur, and now the distal segment, the distal end of the distal segment, is pointing medially, and we've got that varus deformity. A nice round piggy is now fitting through that gap, whereas here, a nice round pig is not going to fit through this gap in the middle. So look, just a little bit more to exemplify the things that I've been talking about there. So here, this is referring to distraction, which is traction, distraction, and displacement would be laterally here. So this would be a small percentage. It's not complete lateral displacement. No angulation, because you see the bones are still straight on. All they've done is done this. So complete lateral displacement. The bones do not overlap at all. You've got angulation, as we talked about. Here, there's angulation, which is exemplified the protractor here. Displacement 2. And then we've got displacement, shortening, angulation. If you were to spin this bone round, you would see that the ends go beyond where they used to meet. Describing a fracture like this is probably not going to come up in your exams. I think that that's, you know, it's quite an advanced description of a fracture, but this is just to exemplify how, if you know your words, you can describe anything that you see, really. I think what's much more likely is they would give you something like this and say, can you describe what you see? And then you would say, okay, so I can see a fracture in the medial portion of the femur. There is, it's a complete fracture, and there is a varus deformity of the distal segment. And that would be good enough to get you the points. So it's a quick whiz through of just a few principles. We're going to get on to some questions now. In terms of the exact examinations for the joints, it will just be worth going through them. I think that we talked about some of the conditions that could come up. I think the exams that I think are most likely to come up would be hand and wrist. I think knee, shoulder and hip are your key ones. I think you should practice all of them, because they could, it's fair game to ask you about any of them, but spine tends to be more difficult to examine. Foot and wrist tends to be less exciting. I think that hip, knee, shoulder and hand and wrist are all pretty fair game. Something that could give you signs or simulated signs, and there's plenty of patients, plenty of conditions that you should know about that would fit the bill for those exams. So I would try and brush up on those extra hard. So we're going to go through now a few multiple choice questions as we've done before, just to test your knowledge, see if we can find any gaps in your knowledge, see what you know well. So I'm going to log into Kahoot, get your phones out. If you get your phones out, use the game pin to log in, and it'll be a similar format. What I'll do, I'll give you a brief, an extended STEM, which is on the presentation. I'll give you a bit of time to think and to look at it, and then we'll tab back over to Kahoot just so you can enter your answers, and then we'll see who is currently the most knowledgeable. And if anybody has any questions at this point, just stick them in the chat. Feel free to fire away, and I will I'll answer them, or do my best to anyway. in theory, I should be quite good at these questions because my BSc, my integrated BSc is in orthopaedic science. However, when I was running through them, I actually did not fantastic. It turns out that I've forgotten quite a lot about orthopaedics. I have brushed up now, so we'll go through these and I'll try and offer you some explanations as to the answers to these questions. So for the first one, here is your stem. A 45-year-old gentleman comes into the ED with a 24-hour history of increasing right knee pain and immobility. He fell off his bike a few days ago and his knee had been fine until yesterday. His knee is red and hot and has reduced flexion and a small effusion. Previously ruptured the ACL in his left knee, and that was treated conservatively. His observations show he has a heart rate of 100, a rest rate of 18, SATs of 98, blood pressure of 102/67, and a temperature of 37.9. His blood results are shown there. His X-ray shows no obvious bony injury. What is the most appropriate next step in management? Discharge him with antibiotics and safety net him appropriately. Start a culture scene and admit him. Perform an urgent MRI of his knee or get ortho down to have a look urgently. So it's quite a wordy question. There's a lot of information to take in there, and the best way to tackle this is to think about what's going on, what's the key pieces of information, scan through that, have a differential in your head and try and convince yourself what's going on based on this stem. Okay, so some observations, think about what they're suggesting. Some blood results, think about what they show. X-ray appears pretty normal. He's a 45-year-old guy, hasn't got much of a medical history. And there's recent trauma, so think about what that might all add up to, and we'll tab across to the answers to this. Tier 1, very good. Not for a while yet. Okay, urgent ortho review. Yes, good. And it's good to see actually that there's been a spread of answers. I think that this isn't a straightforward question, and I'll talk about why it's an urgent ortho review. So, right, off to a good start. So, the answer for this was urgent ortho review, and the reason is the question is getting at a diagnosis or a possible diagnosis of septic arthritis, which is an emergency. A few things pointing towards that. So we've got recent trauma. The joint is red, is hot, and there's a limitation in movement, which is a bad sign. So things to look out for in septic arthritis are a reduced range of movement or an inability to weight bear. Those are key parts of the history. He's borderline tachycardic. He's got a low-grade temperature. His white cell count is raised. The CRP is raised. So those are all sort of soft indicators for septic arthritis. And the key point here is that if you suspect, like in any red hot joint, you need to rule out septic arthritis because it can very quickly destroy the joint. So there are loads of differentials for a red hot joint, and when you see a red hot joint, you need to rule out septic arthritis, because for the other causes, you can sit on them without causing a problem. But if it is septic, that joint, the infection will quickly lead to destruction of the joint, destruction of bone, and will therefore become a life-changing problem. If you discharge him with oral antibiotics, you know, it may treat the infection, but you're not guaranteeing that it's going to do that. Yeah, you've safety netted, and you know, it's always a good idea if somebody's leaving hospital to give them appropriate advice as to when to come back. But all of these are pointing towards septic arthritis, which needs IV antibiotics, really. Starting culture scene and admitting for observation. If we've ruled out septic arthritis and this turned out to be gout, which, you know, it could be, if you've got a really acutely swollen joint, you could have a low-grade fever with gout, particularly in a larger joint, because it could be causing systemic upset. It can cause a rise in your white cell count. It can cause a rise in your CRP. The reduction in flexion is less likely with gout, but this could be a reasonable decision if it was gout, but we haven't ruled out septic arthritis yet. An urgent MRI knee, it's not going to actually offer anything. What matters here is not exactly how it looks, because gout versus septic arthritis versus pseudo gout versus an acute rheumatoid joint versus an acute swelling secondary to hemarthrosis, it's all going to appear relatively similar on MRI. What's going to matter is actually what's in that joint, what's causing the swelling. So what you want is ortho to get down urgently. They'll do an aspiration of the joint and send that fluid for testing. And if that fluid comes back as turbid, high white cell count, culture positive, then you're dealing with septic arthritis, and it's going to be IV antibiotics and treat the infection there. So the point to hammer home for this one, red hot joint is probably the most important topic in MSK. So for rheum and ortho and trauma, because it encompasses all three, there's lots of differentials: gout, pseudo-gout, septic arthritis, reactive arthritis, gonococcal arthritis, rheumatoid arthritis, osteoarthritis, hemarthrosis. All of them can cause an inflamed, acutely swollen joint, and it's up to you to tease out which one it is, and that's going to be down to the history. It's going to be down to investigations, of which joint aspiration is a key one, and then it's about making sure in those situations that anybody that could be suffering from septic arthritis is investigated for it and started on treatment promptly if the investigations prove that they've got that. So this is a really key thing to read up about, because it's really fair game for multiple choice questions. Okay, next question. A 42-year-old woman, past medical history of rheumatoid arthritis, presents to her GP, 2-week history of increased inflammation and pain in the wrist of her right hand. She feels more generally fatigued and has noticed a drop in her energy as she has taken to having an afternoon nap. She's currently treated with sulfasalazine. On examination, the wrist is swollen, but it is not erythematous or hot. The GP takes some bloods, which show the following. What is the most appropriate next step in management? So this is kind of following on from, this is a different kind of red hot joint. Well, it's a different kind of acutely inflamed joint, sorry. It's not erythematous or hot. So appears to be some acute joint pain. How are we going to treat it? What do you think is going on? And what are we going to do to manage it? This time she has got a past medical history, so she's known to have rheumatoid arthritis. Is that what's going on here? Is it something different? Is it the same thing? It's up to you to try and work out, and then from there, see which of those medications would be most appropriate to help her. Okay, so had a chance to look at the blood results, have a chance to digest the stem, so we'll tab over to next question. Okay, good, really good. I got this wrong when I answered it earlier on. So IM methylprednisolone is the right answer. Again, there's a spread, and this is good because it means that I can illustrate some points to you, and it's hopefully identifying some gaps in your knowledge where we can improve. Let's just see the tables. What we're getting on. Nice tennis elbow. Right, so IV antibiotics doesn't sound like septic arthritis, does it? There's not anything at the moment to suggest why she should have a septic joint. Also things that go against that diagnosis: erythema, hot joint, normal white cell count. Probably not going to be septic arthritis. She's got some pain, but it's not excruciating. So IV antibiotics are unlikely to offer any benefit here at all. Methotrexate, it may well be that we add in methotrexate to help manage her in the future. The reason why this isn't going to offer any benefit now, I think the people that have answered this have correctly identified she's having a flare, she's having an acute flare of rheumatoid arthritis. This could definitely be something that is used to help manage that. Things that go against it are the fact that we want to try and help her now, and this takes 2 to 3 months to work. So the DMARDs, the disease-modifying anti-rheumatic drugs, can be used in combination, or often used in combination, but all of them, methotrexate, sulfasalazine, leflunomide, hydroxychloroquine, they all take a few months to work. So 2 to 3 months is the rough time of onset for these medications. So we could definitely start that. And that's not to say this is not a wrong answer, but it's not the most appropriate next step because it's not going to treat the pain that she's having right now. So that comes down to which steroid preparation are we going to use, and basically it's a toss-up between these two. The reason why it's not IV hydrocortisone is because IV steroids are just not used in the management of rheumatoid arthritis. Steroids have a lot of side effects, and you want to use them in the most direct way possible. So basically think of it in the order of intra-articular if you can, if not intramuscular, and if you can't do intramuscular or intra-articular, think about oral steroids. So basically IV steroid is never used for rheumatoid arthritis. In the wrist joint, you're not really able to get intra-articular, so not in the same way that you would be with a knee, for example. So IM methylprednisolone is what we're going to use, and a lot of you knew that, which is really good to see. So this is a little bit about what I've just talked about. When you're initiating treatment for somebody, you've been through your dad's 28. Somebody's got a typical history. We've diagnosed somebody with rheumatoid arthritis. You're going to start them on a DMARD, but typically nowadays you offer bridging therapy as well with steroids because, as I've mentioned, these take ages to start working. Usually quite good, but you want to give somebody acute relief now because it's likely they've been suffering for a while. Somebody has a flare, what are you going to do? You're going to use steroids to induce remission. You can use NSAIDs as well, the lowest effective dose for the shortest possible time. And that's just a general principle for using NSAIDs. They do have side effects. They impact on your renal function. They give you stomach ulcers. So PPI cover is important. And then maintaining remission, there's a very clear, nice guideline on this. It's a stepwise approach. So you start with a DMARD. You can use DMARDs in combination. You can then move on to using TNF alpha blockers, and then there are more specialist biologic agents beyond that, like rituximab and that kind of thing. Basically, all of these are prescribed by secondary care. So if you're in GP, and it's going to be the GP that's coming across somebody presenting with rheumatoid arthritis for the first time, what you're going to be doing is getting a nice clean history. So if your OSCE station is in the GP surgery, your management plan could say, we're going to think about these kind of medications, but it's the remit of secondary care to prescribe them. They can be continued by the GP and monitored by the GP, but initial prescription is going to come from a rheumatologist in the hospital. You've got to be careful about previous infections as well, because these are essentially immunosuppressants. So you need to do specific monitoring, and workup for things like TNF alpha blockers includes screening for TB. Because if somebody has got latent TB and you're giving them powerful immunosuppressants like this, you risk making them really, really sick. So make sure you've got a rough idea of what monitoring is done in terms of bloods, and what kind of pre-regime workup is done for these sort of stronger immunosuppressive drugs. Okay, next question. A 53-year-old female has presented to your clinic with lower back pain. She's been experiencing a dull ache for over a week, and it is notably affecting her when she is seated. The pain does not radiate. There is no evidence of any bowel or urinary incontinence or saddle paresthesia. She has no relevant past medical history and is not currently taking any regular or over-the-counter medications. On examination, there is a good range of movement when bending forwards and backwards. There is tenderness over the paraspinal muscles of the lower back, but no central spinal tenderness. Patient is able to straight leg raise on both sides without causing pain. What is first-line analgesic recommended in this patient? So we've got amitriptyline, codeine, ibuprofen, and paracetamol. I'll give you just a few seconds to read through that step again, try and pick out the key points from the history, and then we'll tab over to Kahoot in order for you guys to answer. Okay, so try and pick out some of the key phrases in this question, see about where this question's trying to lead, and think about what these medications would be used for. Each of them is pointing towards a rough diagnosis. If you can work out what this is trying to get at and what these are trying to get at, then you should be able to answer this question. So let's go over to Kahoot. Good, really well answered. I thought this one was quite tricky, actually. It's basically, it comes down to whether or not you know your NICE guidelines. So back pain is, again, another really key topic. So red hot joint is key, back pain is key. And the reason they're key is because they're common and they're important. What we're getting at here is a diagnosis of non-specific back pain or uncomplicated back pain. There's nothing in this history to suggest malignancy. There's nothing in this history to suggest traumatic injury. There's nothing in this stem to suggest that there's neuropathic pain. This is a case of non-specific back pain, and the way that NICE recommend treating this pharmacologically is with NSAIDs. So paracetamol is not used first line. It's a safe medication, but the evidence shows that it's not that helpful in this case. Amitriptyline, if this was a stem suggesting neuropathic pain, amitriptyline would be great. But there's nothing here to suggest that this patient is suffering neuropathic pain. If we change the stem slightly to say that there is pain on straight leg raise, and if it were to say that the pain radiates down into the buttocks and the leg and down into the toes, at straight leg raise, recreating that exact pain, which could feel like burning or electric shocks, then that's classical radicular pain, which is pain due to irritation of those nerve roots coming out of the lower back. Amitriptyline would be perfect for that, but we're not getting that description here. Codeine or potentially diazepam is useful for an acute injury, and the reason for that is it's not so much down to the pain relieving effect, actually. So the reason that diazepam is used and codeine can be used is more to just get to people to relax. It's not treating the pain as such, it's just getting people to avoid aggravating it and to relax a little bit more. Ibuprofen, anti-inflammatory. Again, you want to use the lowest possible dose for the shortest possible time, and make sure that if they're having it for a sustained period, so in Salford, the prescribing rules around PPI cover, it's for anybody over the age of 45 that's taking an NSAID for beyond sort of PRN basis. So what you should be advising for people that have this kind of pain is that they take ibuprofen and you give them some PPI cover if they need it, and they use that analgesia to make sure that they stay active and they do some self-management. So in GP, what you would do is print off some exercises. There's lots of good websites that give you stretches for back pain, and just tell people to keep that up. You can refer people to physiotherapy, and that's really helpful for this kind of thing. And for the time being, this doesn't need further investigation, further management. If somebody comes back to you, if they've been really religious about taking their medication and they've been doing their physio and the pain is ongoing or getting worse, or if it changes in nature, then that may prompt you to investigate further. Know about the red flags of back pain, because it's really important. As I said, there's loads of different reasons for getting back pain, and what you need to be able to work out if you're asked to take a back pain history is this something that I need to be worried about? So we've alluded to some of those red flags in the stem. So bowel, urinary incontinence, saddle paresthesia, if they're getting weakness or loss of coordination when walking, those are all things that you should be worried about. It could be that you've got a history that describes an older gentleman, maybe has a past medical history of prostate cancer, and all of a sudden he's presented because he's soiled himself on a couple of occasions. That needs to be ringing alarm bells, and that would be, 2-week wait, get them to hospital, get them scanned urgently, because you need to see if there's any kind of like spinal cord compression. Okay, next question. So Margaret is a 60-year-old woman who enjoys taking her grandson on long walks in the countryside and regularly tends to her garden. Last night she tripped over her cat and she sustained a neck of femur fracture. The frontal, which is this one, and oblique views are shown here. What is the most appropriate management for Margaret's hip fracture? So this is an easy question if you know it, and it's a difficult question if you don't. Have a look at this X-ray. See if you can appreciate where the fracture is. I'll admit it's not very easy to see. And maybe that tells you something, but have a look at the X-rays. Work out what kind of fracture you think that is, and then based on the images and based on the stem, how are we going to help Margaret with that injury? Okay. Let's tab over. Okay, I'm pleased to see that this has got a mixed bag, because we're going to go through thoroughly why the answer is internal fixation. Tennis elbow's having an absolute stormer so far. So Margaret is a 60-year-old woman who has a good functional baseline, and that's important. So that's immediately putting her into a category that separates her from poor functional baseline. In a fracture like this, and can I convince you that this is the fracture here? So it doesn't appear, or at least to mine, maybe you can see a little bit there, but it's not obviously going all the way across, and it certainly doesn't appear displaced. We've got a few options here. It's an intracapsular fracture. So when we're talking about neck and femur fractures, which are a really important topic for your exams, because again, they're common and they're important. They can have serious morbidity and mortality if they're not recognised. So this is the intracapsular region. And then you've got the extracapsular region. So the reason why this distinction is made is because there are different implications for fractures in these two regions, and they are therefore treated in slightly different ways. When we're talking about intracapsular fractures, like this one, we use the Garden classification to work out how severe it is. So we talked earlier on about how to describe fractures. The Garden classification 1 is an incomplete fracture that is minimally displaced. Garden 2, non-displaced and a complete fracture. Garden 3, complete, partially displaced, and Garden 4, complete and totally displaced. So basically, these are worse prognoses as you get on. Garden 1 and Garden 2 have less risk to the blood supply in this area, and Garden 3 and Garden 4 have more risk to the blood supply in this area, and those again mean that you're going to manage them slightly differently. How can you tell if a fracture is displaced? An easy way is to take a look for Shenton's line, which is this medial aspect of the femur going into the posterior aspect of the pubic ramus. So look for a nice smooth continuation. So this is what looks to be quite a young set of hips. If we go back to our x-ray, this is an older person. It's not quite as beautifully defined, but hopefully I can convince you that there isn't massive discontinuity in Shenton's line. It doesn't look like this cortex is disrupted as we sort of trace our way around. So this is a non-displaced fracture. So what we've got is an intracapsular fracture that is Garden 1 by the looks of it, but if it's Garden 2, we're not going to manage it differently. So it's this end of the spectrum. And what that means is there is less risk to these vessels, the medial circumflex, the deep femoral, and the lateral circumflex. If you have a partially or totally displaced fracture, you risk causing rupture of these blood vessels, and rupture of these blood vessels puts you at risk of avascular necrosis of the femoral head. Femoral head needs a lot of blood in order to maintain its quality. If you rupture the blood supply, the bone basically starts dying away, and that can lead to pain, infection, morbidity, mortality. It's not a good thing to have. So there are some nice rules for how to manage intracapsular fractures. So we said that Margaret has a good functional baseline. It basically pulls us into this category here. If we go back to those, these are the possible options that we were offered. She has a good functional baseline, so we're thinking about internal fixation if we can. She's 60, so even if it were displaced, internal fixation, which is done with a cannulated hip screw, which is different to a dynamic hip screw. Internal fixation is what we're going to try and do. If Margaret were 70, or if Margaret was 75, say, or if down to her anatomy, due to interoperative factors, it meant that it wasn't possible to do internal fixation, a total hip replacement is what you would do, because the risks of this operation, they're quite small. It's a good operation, but you're aiming to get function back. Poor functional baseline, hemiarthroplasty is used for these patients because it doesn't give you the same freedom of movement, but there is less risk involved in a hemiarthroplasty than in a total hip replacement. What you're trying to do is just relieve pain and prevent complications such as avascular necrosis, because what you're going to do is just take away that head. In a hemiarthroplasty, you are just replacing this aspect of the joint. So when you see an intracapsular fracture, think about, is it non-displaced? Is it displaced? What is their functional baseline? Is it good or poor? If it's poor, just going to hemiarthroplasty them. If it's good, you've got a decision to make between internal fixation or total hip replacement. And then with an extra capsular fracture, so if it's intertrochanteric, or if it's if it's intertrochanteric is one type of fracture, you have oblique, you have reverse oblique, you have subtrochanteric. Those are fixed in a different way. So non-special type, dynamic hip screw. So basically, if it's intertrochanteric, reverse oblique, as I said, is like this. So that would be an IM nail. Subtrochanteric, so totally below this, would be an IM nail, and transverse, like that, would be an IM nail. But all other cases of extracapsular would be a dynamic hip screw, which, as I've said, is different to a cannulated hip screw, which is used for internal fixation. So hopefully that gives you a better understanding of why Margaret, in this situation, 60 years old, fit and well, why in this scenario we've had to go for internal fixation. I think this is really easily testable in an exam, because that's a short stem. It's got an X-ray with it. I would recommend knowing this well, because it's something that shows a little bit of insight on your part, and it's very easy. It's so quick and easy for them to just write a question about this. Nice short stem, put a picture to it. Do you know what this is? And if you can basically work out from those criteria, think about the baseline, and they'll make it really obvious if it's good or bad. They're not going to put somebody who's a kind of middle ground. They're basically going to go for, they'll give you somebody like Margaret who loves going for walks and tending the garden, that kind of thing. Or they'll give you an 80-year-old woman who's bedbound, and she's rolled out of bed and that's broken her hip. Those would be your two options in any question. Know about displacement and know about intracapsular or extracapsular, and that's marks in the bank. If anybody has any questions about that, please do stick them in the chat, because I'll be happy to try and explain that a bit clearer if there's any issues. Okay. In the meantime, we'll move on. A 70-year-old woman presents because she is feeling generally run down and has muscle aches. The back, arm and thigh muscles ache and are stiff, particularly in the morning. These symptoms have been present for the past 2 weeks. Prior to this, she was generally fit and well. Clinical examination is unremarkable, other than some tenderness over her deltoid and thigh muscles. Muscle strength is normal. What is the most likely diagnosis? So fibromyalgia, rheumatoid arthritis, polymyalgia rheumatica, and polymyositis. Okay, so again, another short stem. A few bits of key information in a short space of time. It should hopefully help you work out what's going on here. Right, let's go over to quiz. Okay, so again, we're splitting the field, and I'm going to tell you about why this is polymyalgia rheumatica and not fibromyalgia or rheumatoid arthritis or polymyositis. So with these rheumatoid conditions, these rheumatological conditions, there's a lot of blurring of exactly what symptoms they cause. So let's think about each of them in turn. Fibromyalgia. This is a 70-year-old woman. Fibromyalgia tends to present in people who are younger than this. So it's a disease that tends to affect people who are in their 20s or 30s or 40s. Tends to affect women more than men. She's feeling generally run down and has muscle aches. Yeah, that could be fibromyalgia, that fits. Back, arm and thigh muscles ache and are stiff. Pain, yes. Stiffness, no. Fibromyalgia tends to be a condition of pain. And also, if you notice where the pain is located, it's her back, her arm and her thighs. So these are kind of the truncal muscles, the muscles that are more the proximal, so thighs, back, arms. Fibromyalgia tends to be widespread, tends to be pain everywhere, and muscle strength is normal. That could fit with fibromyalgia. Prior to this, she was generally fit and well. With fibromyalgia, you tend to have yellow flags, as they're called, and basically that describes a previous history of chronic health conditions, of medicalization, of maybe institutionalized people that have previous poor mental health. It paints a picture of people who have been to the doctor a lot, tend to be diagnosed with fibromyalgia. And, that's rightly or wrongly, it's a condition that's not very well understood. It could be in future that there is antibodies or some other investigation that is tied to why people get fibromyalgia. But at the moment, it's seen as partially a psychosomatic condition where people's mental well-being feeds into symptoms of pain. It's thought to be an element of allodynia, which is people having pain response to non-painful stimulus, and also hyperalgesia, which is people feeling more pain than they should normally do to painful stimuli. So fibromyalgia does fit with some of this, but you would expect it in a younger person. You wouldn't expect stiffness. You would expect a longer history than 2 weeks. It would present over months, and it would be in somebody who tends to have a little bit of a mental health or a chronic health history. So that's why it's not fibromyalgia. With rheumatoid arthritis, it can present this late. Again, it tends to present a little bit younger than this, sort of 40s and 50s and that kind of age. It's in the muscles, so it's not really in the joints. That's where you see arthritis. arthritis is obviously inflammation of the joints. That's what that means. 2 week history. Rheumatoid arthritis can present that acutely. It tends to be chronic, but in acute inflammation, if this was rapid onset, which you can see with rheumatoid arthritis, it could be over 2 weeks. And what it boils down to is the fact that this is muscle symptoms, not joint symptoms. So rheumatoid arthritis is not the right answer in this situation. Polymyositis is an inflammatory condition, tends to affect the muscles, and it causes pain, but causes weakness as well. Muscle strength is normal. Polymyositis causes weakness, so it immediately rules that out. There's a crossover with dermatomyositis, so you often see rashes as well. It says here that clinical examination is unremarkable, other than some tenderness of these muscles. Polymyalgia rheumatica is a condition that's not very well understood. Not exactly sure why it happens, but there is inflammatory change that is usually a subacute onset. It causes pain and stiffness, but doesn't cause weakness. There may be some apparent weakness, but that's usually down to pain limitation rather than true weakness. So make sure that you try and tease that out in an exam if you think that you're seeing somebody being truly weak or if they're being limited by pain. So you can examine and you can ask people that. If you say, oh, can you lift your legs off the bed for me? And you can ask them, now, were you unable to lift it as high as you wanted to, down to pain, or is that because you were just unable to move it? And they'll probably tell you that it was down to pain. So the clues in this stem, the subacute onset, the age, the general malaise, the muscle aches, and the normal power point towards PMR being the diagnosis. Check the ESR. ESR is typically raised, not always, but it's typically raised in PMR. If you've got the diagnosis right, if you've got a history like this, if you've got the diagnosis right, put them on prednisolone, because if you put them on high dose pred and you've got the diagnosis right, their symptoms just melt away. It's in a matter of days that happens. And make sure you ask them about visual symptoms. PMR is very closely tied to giant cell arteritis or temporal arteritis. And if they've had symptoms of sudden onset visual loss, and it can be temporary at first, but it becomes permanent if it's not treated. And it's that classic amaurosis fugax, that curtain falling is what they describe. So ask people, have you had any visual changes? Have you noticed any shadows or any loss of vision? And if they describe something like that, then they're going to need to be on an even higher dose of steroid in order to treat that. Not everybody that has PMR gets GCA, but most people that have giant cell arteritis will suffer from polymyalgia rheumatica. So ask about visual symptoms, because it's really important, because you don't want to leave somebody permanently blind. Okay, so we're moving on to, it's the same lady. We've diagnosed her with PMR and we've started her on high dose prednisolone. What are we going to do next in order to help this lady? Is she going to need a DEXA scan? Are we not going to worry about it? If we look at her past medical history, it doesn't mention anything about a previous fracture or any falls or anything like that. So we're going to do a DEXA scan. Are we going to reassure her? Are we going to start vitamin D and calcium, or are we going to start bisphosphonates and vitamin D and calcium together? Okay, it's a nice short question, so we'll tab over quite quickly. Ladies on high dose steroids, what are we gonna give? Good. So again, there's a mix, and I'll tell you why that was the right answer. So There are some now outdated Royal College of Physicians guidelines. There have been some recent changes that have been brought in by sort of an osteoporosis combined task force, which is between like the Royal College of Orthopaedic Surgeons and the Royal College of Rheumatologists and that kind of thing, which have given similar advice. And essentially the advice boils down to this: patients taking the equivalent of more than 7.5 milligrams of prednisolone per day should be offered bone protection. So patients with polymyalgia rheumatica, high dose prednisolone, so that's more than 15 milligrams per day. Essentially what this is getting at is she's going to be on a lot of steroid and she's going to be on it for a long time. So they're normally on this treatment for months at the least in order to make sure that this condition doesn't come back. So patients in that situation, long-term high dose steroid, should be offered bone protection, and that means bisphosphonates. You want to optimize everything else, so give them vitamin D and give them calcium, but they need to be on alendronate as first line, so alendronic acid. Other things to know about osteoporosis, so know about the risk factors, know about who is liable to get osteoporotic fragility fractures. So think about its increasing age, it's postmenopausal, particularly as a risk factor. Women, low BMI, smokers, people who are inactive, and long-term steroids is a big one. If they're not on steroids, you want to think about doing a FRAX score, and that suggests people who should either go immediately onto bone protection, or it suggests when people should go for a DEXA scan. With a DEXA scan, if their T-score, so their deviation from the normal population, the healthy population, is minus 2.5, you should be offering bone protection, and that is alendronate. What they might ask you about with alendronate is how to take it. That's something that's sometimes asked in exams. It's a medication that you should take first thing in the morning, 30 minutes before you have any of your other medications or before you have your breakfast. People should take it and they should stay upright. It has quite a profound, can cause quite profound irritation of the esophagus if you take it and you start lying down or sitting down. So you want to make sure that you take it and you spend half an hour sat upright in order to reduce the possibility of esophagitis and reflux. So make sure you advise people this needs to be taken first thing in the morning. Give it half an hour. Make sure that you're sat up straight before you move on to having your breakfast and your other medications. Okay, next question. So Mary is a 29-year-old woman, comes to see you with fatigue, muscle aches, dry eyes. She has a red-purple rash over her cheeks, and that happens when she spends some time out in the sun. She has also been getting frequent mouth ulcers. You suspect a diagnosis of SLE. Initial bloods reveal anemia, and urinalysis shows proteinuria. Which of the following tests is most appropriate as a rule-out test for this diagnosis? So, which of these tests, if it came back positive or negative, which test could rule out SLE most effectively? So you need to try and get your head around what this question is, what it's asking you. Basically, which test is most effectively going to pick up SLE? So, which test is going to pick up SLE? or rule it out in this case. Good. You've answered that very well, guys. So we'll talk about why that's correct. So there are loads of different autoantibodies, and you should know about a few of them. Knowing all of them intimately is great if you've got the time. I would argue that there are higher yield ways of spending your time, but there are a few that you should probably know. So the reason why anti-nuclear antibody, ANA, is the best one as a rule out is because 99% of cases of SLE will be positive for anti-nuclear antibody. If you think that this is SLE, but you think there could be other things going on, a quick way to find out if it's SLE or it's something, if it's something else, would be test for anti-nuclear antibody, because 99% of cases of SLE are ANA positive. If this person was ANA negative, that would tell you that this is probably not SLE, even though all of the signs and symptoms are pointing towards that. If it came back negative, probably not going to be SLE. The reason why it's not these is because they're much less sensitive, and that's what this question is putting to it. So rule out tests, you want a high sensitivity. The reason why these are included is because, so this is complement level. It's not really specific. It could be loads of different things. It's not specific to SLE. Complement level tends to be depleted, so can be useful as a marker of active disease. Anti-double-stranded DNA can also be used as a marker of active disease. Complement level tends to, your C4 and your C3 and C4 tends to get depleted when you're having an active flare of SLE. Anti-double-stranded DNA and anti-Smith are markers that are very specific to SLE. So let's have this one. Anti-double-stranded DNA, 70% of people who have SLE have anti-double-stranded DNA. And if you see anti-double-stranded DNA, 99% of those cases are SLE. So it's quite sensitive. Most people who have SLE will have this. And if you have this, it's basically guaranteed that you have SLE. With anti-Smith antibody, this is the most specific. Most people who have SLE do not have anti-Smith. So when you test for this in a panel, it's probably not going to come back as a positive result. But if it does come back as a positive result, you've basically clinched the diagnosis. This is the most specific antibody for SLE. ANA, loads of different things, loads of different conditions have ANA. So let me see if I can find a list of them here. So SLE, systemic sclerosis, autoimmune hepatitis, rheumatoid arthritis, Sjogren's, and a healthy population. It could appear in everyone. So that's not that helpful for telling you what is happening, because it's not very specific. But if somebody doesn't have this, it's not going to be SLE, because SLE patients have this. When you do a biplex CTD on SLE patients, they will probably have this marker positive. And other important ones to know about, so rheumatoid factor, the first autoantibody that was really known about 70% sensitive. Anti-CCP is a good one for rheumatoid, because if you see this, again, you're basically diagnosing rheumatoid arthritis. With the autoantibodies, the ones to know about are the important ones. So rheumatoid factor is an important one to know about because it was the first one that was discovered. Know about the sensitive ones, so ANA, which is great for ruling out, and specific ones, because if you see anti-CCP, you diagnose RA. If you see anti-double-stranded DNA, you diagnose SLE. Anti-Smith, you diagnose SLE. So have a rough idea. There's loads more. They're usually going to be a clue in a stem. So you see a stem like this, what it might say is Mary's a 29-year-old woman who has symptoms of fatigue, muscle ache and dry eyes. She's developed a red-purple rash on her upper cheeks, which she notices after she's been in the sun. On further questioning, she tells you that she's been getting mouth ulcers frequently. Initial blood tests reveal anemia, an anti-double-stranded DNA, and urinalysis that's positive for proteinuria. What is the most likely diagnosis? So, you know from the clinical signs, this would just be one element of that stem. It wouldn't be the clincher. It wouldn't be the only piece of information that's going to make that multiple choice question for you. Like, you'd have plenty of other opportunities to seal that diagnosis. I think you'd be very hard done by if you were to get a question that said, this antibody, what is it? Because it's not that important when you actually get to working. What they want to probably see you do is tease out from a stem like this, how do you know what condition that would be overall, rather than just based on one piece of information. Okay, so next question. 25-year-old woman presents with a swollen first finger and wrist pain associated with a 4-month history of generalized fatigue. She has no other symptoms, including no skin changes and no previous medical history. Her mother suffers from psoriasis. She had the following blood tests as part of her investigations. What is the most likely diagnosis? So I'm basically testing if you were paying any attention to what I've just said. We've got a stem. We've got some information here that's going to help us make a diagnosis, but it's not essential. Other things in this question are going to help lead us towards a diagnosis as well. So can you put all of those clues together to come to the right answer? Okay. Good. Okay, so again, what I'm trying to do here is just give you some difficult questions, some thought exercises, and we'll talk about why. So rheumatoid factor is negative. So 70% sensitive for rheumatoid arthritis. Rheumatoid factor picks up 70% of cases of rheumatoid arthritis. It's negative, so it's unlikely to be rheumatoid arthritis. It could be one of the 30%, but there's other things that point away from it as well. ANA negative. So this is 99% sensitive for SLE. ANA is negative, so it's not going to be SLE. Like, we can rule that. That's a great rule out test, because this is negative. We can forget about this now. It could be that. There's still 30% of cases that could be one of those rheumatoid factor negative cases of rheumatoid arthritis. Osteoarthritis. So 25 years old. She's too young, really, for osteoarthritis. History of generalized fatigue. She's got constitutional symptoms. She's got a raised ESR. All of that goes against osteoarthritis, so forget about this as well. And then it basically comes down to what's more likely. So she's 25 years old. Could be either of those. Swollen first finger and wrist pain. Could be either of those. Constitutional symptoms, that 4-month history of generalized fatigue, could be either of those as well. She has no skin changes and no previous medical history. Again, it doesn't rule it out. Psoriatic arthropathy is not psoriasis, it can present alongside it, but you can have joint changes without having the skin changes, the classic psoriatic plaques. She has a family history of psoriasis, so that puts her at more at risk of psoriatic arthropathy. Doesn't rule out rheumatoid arthritis, because again, it can go hand in hand. And following blood tests, ESR raised points towards psoriatic arthropathy, rheumatoid factor negative. On the balance of probability, it's probably going to be this, and that's the right answer for this question. So that is the end of this presentation. We've pretty much kept the time this week, which makes a nice change. So if you guys have got any questions, please stick them in the chat. If there's anything that I can help clear up for you, because we've got a little bit of extra time. And if you don't mind, I'm going to stick another feedback form in the chat as well. Oh, let's see. Did we see one? Let's move over. So, hi, has done very well. Tennis elbow, second. Congratulations, Steph. Good work. So I put in 8 hard questions. To get 6 out of 8 is pretty impressive. But I think that, again, I don't want you guys to get down if you're not getting these right. The reason that I put in these questions each week is not necessarily to, you know, I don't want to make them easy ones, because we want to use things to illustrate teaching points and make them sort of bring a little bit of colour to the teaching topics. If you're getting them wrong now, you're hopefully going to remember the reasons why you might have got them wrong, and that's going to put you in good stead for when the real exams come around. So please don't hesitate to ask me any questions based on what we've talked about today. I think that the key topics that you want to know about, there's loads to cover in rheum and ortho and trauma for your exams. The stuff that they're going to want you to know about is the stuff that's common, and the stuff that is serious. So rheumatoid arthritis, osteoarthritis are really important for these exams. For neck and femur fractures is really important. For osteoporosis and some of the other rheumatological conditions. Things like primary bone cancers are less important for your exams. If they're going to be asking you about osteosarcoma, you know, that's only going to be, you're going to have one question maximum that would come up on a primary bone cancer. I think if you're pressed for time coming into your exams, you've got loads to cover. Things that are really rare should be bottom of your priority list. So think about back pain, think about common rheumatological conditions, think about things that have a significant disease burden in the population, and that's the stuff that you should try and focus your energy on if it's getting to crunch time. Okay, guys, we'll stop recording, and